we've been talking about finasteride a lot on this channel, and most experts that we have had on before, they all are against the use of it. Yeah, because of possibilities of post-finasteride syndrome, a lot of risks for erectile dysfunction and libido loss. So what's your maybe more nuanced take on this matter? Are you a proponent of using finasteride?
I don't really claim to be for or against using any medication. I call my clinic service individualized medicine because it takes into account each individual's, predisposition and also each individual's genetics. So the way that I sometimes explain finasteride is it inhibits 2 of the 3 isoenzymes of the 5-alpha reductase enzyme. So you think of your bloodstream as the pipe or the plumbing, that's where it flows in between, and 3 different types of cells. One of the cells that it inhibits 5-alpha reductase in is the cell that has the hair follicle. One of the cells is the cell that is in genitourinary skin. So, for example, penile skin or scrotal skin. And then the other one is in the rest of the skin in your body. So your body has many different feedback inhibition mechanisms, but when you're thinking about androgenic or anti-androgenic side effects, for example, loss of sensitivity, loss of libido, changes in the brain, it's not just the androgen receptor and the progesterone receptors that you have to look at how often they're bound, but it's also how strongly they're bound. So for someone that has a very sensitive androgen receptor, they often do not need as high of a level of DHT to get the same amount of gene transcription. The way I explain that is it's like a door, and some people just genetically have a very heavy door. That's the androgen receptor, so you need a stronger androgen to push that door open. And on top of that, there's also a change in androgen receptor density. So that is likely why we see very frequent side effects with finasteride, because your body detects that one of the buckets, that's the cell, for example, in non-genital skin, it detects that there's a normal level of DHT in that cell through various feedback mechanisms. So it is not going to change like heat shock protein signaling from androgen receptor density and whatnot. Whereas if you have the level of all those 3 the same, then it is much less likely that you will have the symptoms. And we see this in studies that compare doses that have the same serum level. So again, that's not inside the cell, it's not the intrachronology, but the same serum level of DHT. You can compare the finasteride and dutasteride, and dose per dose, dutasteride has less side effects. That being said, classically, when dutasteride is taken for benign prostate hyperplasia, it's taken at very high doses. It's kind of the same thing with finasteride, although 5 mg and 1 mg is not really that different of a dose when it comes to pharmacodynamic effects. So that's a lot of words and a long story, but I guess the 1,000-foot view of that is, yes, side effects are relatively common with finasteride. It's important if you're a candidate for it and there's not a better treatment option, and often there is better treatment options. But if you're a candidate for it, you need to look at your estrogen to androgen ratio. You need to look at your free androgens across the board, not just free DHT, but also free testosterone. Accurately assay your estradiol, so likely not an ECLIA, especially if you're producing your own endogenous testosterone and it's aromatizing. And then also look at, finally, your progestogens. So I call it the progestogen pool. It's your pregnenolone plus your progesterone. Get an idea of how much progesterone is 5-alpha reduced and crossing the blood-brain barrier. It is, of course, a very nuanced topic. I believe James and I have our podcast on hair loss that focuses on this a lot. It'll probably be 3 hours long. That will be very reference-heavy. But I love talking about it, and I love the pharmacology of it. So hopefully that kind of helps explain the nuance behind 5-alpha reductase inhibitors.
Sure thing. And what other maybe better options are there for prevention of treatment of male pattern baldness?
Yeah, the more it is related to the hyperandrogenic signaling, so the excess gene transcription at the androgen receptor, the more you need to consider what I would call anti-androgens. Now, if it's a mixed picture, sometimes growth agonists can help. Growth agonists would be like minoxidil, PRP, many peptides. Anti-androgens would be 5-alpha reductase inhibitors. Topical as well are often good choices. Of note, not as much topical finasteride. That significantly goes systemic. Depending on the dose of topical dutasteride, a clinically insignificant level, like it does go systemic as well, but it is usually clinically insignificant. So dosing for topical dutasteride is extremely important. And then there's other topical anti-androgens that are in development, basically cousins of RU58841. One's in Breezulub, but that one's been stuck in phase 2 or 3 for a long time. So there's several promising prescription anti-androgens. And then I always like talking about caffeine, and then I always like talking about ketoconazole. Spironolactone also goes systemic, but most of it's metabolized before it goes systemic, but probably not all of it depending on the dose. So there's a lot of options for topical anti-androgens. Neuromodulators are another topical anti-androgen. And then there's definitely a difference between mesotherapy and topical. So topical, you're thinking about a solution directly on the scalp. For some things, you want to microneedle. For some things, you definitely do not. Sometimes you can combine these in a device like an Aqua Gold, where you can develop, deliver PRP and like a non-immunogenic neuromodulator, like a botulinum toxin at the same time. And then depending on where you're at, basically if a sterile compounding pharmacy makes topical dutasteride, you can do mesotherapy for that. But the dose is definitely not the same for solution of dutasteride versus mesotherapy of dutasteride.